Sharma, Treasurer of NIMA Central. Also, a very warm welcome to Dr. Kamini Diman, Madam, President of NIMA OBGY Central, Dr. Priyanka Nakare, Madam, Secretary of NIMA OBGY Central, Dr. Vishnu Bhavne, Sir, Treasurer of NIMA OBGY Central, and Dr. Rajesh Utane, Sir, Convener of NIMA OBGY Central. We are also delighted to have Dr. Suhas Helekar, Sir, President of NIMA OBGY Maharashtra, Dr. Manoj Gaikwad, Sir, Secretary of NIMA OBGY Maharashtra, and Dr. Ajay Raj Bal, Sir, Treasurer of NIMA OBGY Maharashtra. So before we begin with today's session, a few instructions which are common to all the participants. Please keep yourself muted during the session. If your mic is found on or disturbing the speaker's voice, you'll be kept in the waiting room or you will be removed from the session to maintain the decorum of the program. If you have any question, you can raise your virtual hand or you can put it into the chat box. So let me brief you regarding the NIMA OBGY agenda. NIMA OBGY, that is National Integrated Medical Association Obstetric and Gynecology Society of India, aims to impact education in supporting and protecting the character, status, and the interest of the integrated medical profession in general practitioners and the practitioners of Sri Rog Prasuti Tantra, that is Integrated Obstetric and Gynecology India. Our objective is to spread and to fasten education in integrated obstetric and gynecology, including human reproduction, family welfare, study and research in the field of contraception and other allied programs. NIMA OBGY is committed to promote services for the betterment of the community, especially maternal and child health, prevention of ailment and disease, the treatment with integrated approach of Indian medicine with modern science. So with this, let's begin with today's 31st lecture of OBGY Bonanza webinar series, Amniotic Fluid, its clinical implication and integrated approach of management. Amniotic fluid, as we all know, it's a complex physiological and a dynamic biological fluid that surrounds the fetus during pregnancy. It provides mechanical protection and the nutrients required for fetal growth and well-being. So we are here to explore what Ayurveda has to say regarding amniotic fluids or Garbhodar, its disorder and their management. Today we have amongst us Dr. Chetna Kumari, Madam, a distinguished clinician. She'll guide us through her novel thoughts regarding today's topic. A very warm welcome to you, ma'am, and we are honored to have you with us. With great pleasure, I would like to introduce you all to Dr. Chetna Kumari, ma'am. She is an associate professor at SKMC Hospital and Research Center, Bangalore, teaching the undergraduates and the postgraduates since 2014 and also guiding the PG students in 2020. Ma'am has completed her BMS from Government Ayurvedic Medical College and her MS from SKMC Hospital and Research Center. Ma'am has also done a Master of Science in Counseling and Psychotherapy from Manasa University, Shivamogga. So with due respect, I would call upon Dr. Chetna Kumari, Madam, to start with today's session. Ma'am, you can begin.
Yeah, thank you so much, ma'am. It is an honor to present in front of you great scholars. But still, I'm happy that you have given me an opportunity to present. So today I'll be dealing with amniotic fluid and its relation and its clinical importance and what will be our clinical treatments which we follow here in Karnataka or in our hospital. So that I'll be dealing with it. So amniotic fluid, the contents with this seminar is one is Garbhodaka, what and all. We have got the reference through Ayurveda or through our acharyas that I'll be telling. And then amniotic fluid, its definition and its function, and the clinical importance of the amniotic fluid, clinically how much importance we should be given for the amniotic fluid, and the volume and its composition of the amniotic fluid and how much it is important, and amniotic fluid abnormalities, when it should be a call that you have to take up. So that and the management, or specifically this we are dealing with the Ayurvedic management with only oral medicines or few Sthanika Chikitsa, how you can treat the problems or the abnormalities related to amniotic fluid. So let's move on to an Ayurvedic point. So that is what and all is being explained related to Garbhodaka or the amniotic fluid in our classics. That is in Charaka, he has told in Sharira Sthana 8th chapter that Prajanana Kala Abhimato Bhavanti Tato Anantaram Avi Pradurbhava Prasekascha Garbhodakasya. That is, once the Avi Pradurbhava has been taken place, then there will be Garbhodaka Praseka. So that is, there will be expulsion of the Garbhodaka. That you can correlate to amniotic fluid. Even Vagbata in Ashtanga Sangraha, he has told the same thing. That is at the context of prasava, that is at the newborn is advised to do the mild vamana, that is either through giving some irritation to his kanta, that which facilitate the vamana for the expulsion of the garbhodaka. So next in Ashtanga Rudaya, what he has told us, he has explained while explaining the Upasita Prasava Lakshana, that the woman who is about to deliver or who is at the verge of Prasava, so in either 1 or 2 days, she will be having the discharge with contractions. That is, with the Avi Pradurbhava, there will be Garbhodaka, you can see at the per vaginal examination, or at the vagina, you can see that there will be discharge. So that these are the few references. And even in Arunadatta, he has told, along with Avi, there will be liquor discharge. That will be, so whatever these acharyas have told, everybody has told. So along with uterine contractions, you can see the liquor discharge. That is the first stage, or that is the direction for us that she is at the verge of delivery. And even Kashyapa, while explaining in the Sharirasthana, he has told there will be leakage of the Jalatattva or the Garbhodaka, along with pain, along with other symptoms like pain at the flanks or the back. He has told the other symptoms. Along with that, he has told there will be leakage of Garbhodaka along with Avi. So this is the sign for the Prasava. So these are the few references which you might get in our classics. So other than this, there is no there is another one reference that they have told, there is the Garbhakshaya. So for that Garbhakshaya also, you can take it as a reference, because in the oligohydramnios, it might end up with the IUGR or the IUFT, that is in the fetal demise also. So in that sense, you can take as a Garbhakshaya, and Garbhakshaya treatment also you can consider for the oligohydramnios. So let's move on to modern, that this Garbhodaka is being explained or it can be correlated to amniotic fluid. Amniotic fluid is the clear yellowish fluid that surrounds and protects the fetus in the uterus. So this amniotic fluid, this is very much important for fetus. So what is the function of this amniotic fluid? So it will help in the fetal growth and the movement of the fetus and the overall development of the fetus. So this is very much important. It helps in the ingestion into the gastrointestinal tract in order for the growth and maturation of the cells in the fetus. And it at around 20th week, the fetal pulmonary development also it will help. And it protects from any kind of trauma or any kind of injury to the abdomen. So it protects the fetus. So it gives as a cushion for the fetus, and it maintains the temperature for the fetus to grow, and it contains antibacterial activity, and it helps in the dilatation of the cervix during labor. So these are the few functions related to amniotic fluid. So the clinical importance of the amniotic fluid. So through the serum alpha fetoprotein, you can screen for the fetal malformations. So the amniotic fluid index for the assessment of fetal well-being under the ultrasonography, and LS ratio you can see for the fetal lung maturity. If LS ratio is less than 2, then you can consider it as an immature lung maturity, fetal lung maturity. If it is more than 2.5, so if at all, if she is diabetic or if the fetus is asphyxiated, then there might be chance for the LS ratio to be more, but many a times it might be false lung maturity also. So we have to be careful while taking the history only. And diagnosis and the follow-up of labor. So in that sense, amniotic fluid will be helpful. And diagnosis of the premature rupture of membrane while doing the Fern test, if at all at the 32nd week or the 34th week, if you do the Fern test, if at all, if it is positive, then there is a high chance that she might end up with the premature delivery or the preterm labor within a week if the Fern test is positive. So in all these cases, so it will be very much helpful. And normal amniotic fluid volume, so in the first and second trimester, amount will be 5 to 50 ml, which arises from the either ultrafiltrate of the maternal plasma through the vascularized uterine decidua in the early pregnancy, and transudation of fetal plasma through the fetal skin and the umbilical cord. That is through this up to 20th week of gestation. This is how the amniotic fluid volume will be slowly increasing. It is the isoosmolar with fetus and maternal plasma, that is through the skin or the uterine muscle. So in this, though it is devoid of proteins, though amniotic fluid is devoid of proteins, but still it is isoosmolar. So then amniotic fluid volume. So from the 20th week up to term, mainly it is amniotic fluid is mainly consists of the fetal urine. Sorry. At the 18th week, the fetus voids 7 to 14 ml per day, and at term, fetal kidneys secrete 600 to 700 ml of urine per day into the amniotic fluid. So this, if there is any variations, you can think if that is after 20th week, if at all, if there is any variation in the amniotic fluid, you can think there might be problem with the fetal kidneys. So that is why the 20th week scanning is very much important. And then fetal respiratory tract secretes 250 ml per day into the amniotic fluid, and fluid transfers across the placenta, fetal oronasal secretions. Through all this, there will be minimal secretions into the amniotic fluid. Sorry. Okay, and secretion is controlled by either fetal swallowing or term removes 500 ml per day. And reabsorption into the maternal plasma, that is osmotic gradient. So this is how the secretion is controlled by the fetus. And the amniotic fluid, what are the constituents of the amniotic fluid? One, it contains the urea, creatinine, uric acid, desquamated fetal cells, vernix, lanigo hair, and the others. That leads to hypoosmolar amniotic fluid. So this is how the amniotic fluid volume is maintained. First one is fetal swallowing and reabsorption by the intestine. This is how it is controlled. So second thing is exchange with respiratory tract reabsorption via lungs. And the third is exchange across fetal skin, possibly only with where there is lipid soluble gases. So that will be with the skin. and the transfers across the chorionic plate through the placenta, and then amnion chorion lavae. And next is net water movement, that is between the mother and the fetus across chorion frondosum. So these are the few things which will be maintaining the amniotic fluid. So this is the pathway of the amniotic fluid. So one is through the swallowing, urination, intramembranous exchange, gaseous exchange or the lipid soluble exchange. And the one is transmembranous, that is through the placenta and the uterine wall. So through all these pathways, the amniotic fluid is maintained. If there is any problem with any of the pathways, that might lead to either the increase or the decrease of the amniotic fluid. So amniotic fluid volume assessment. So clinically assessment, it is very unreliable. Approximately, if there is major variations, you can check clinically. Otherwise, it is not, you cannot assess the amniotic fluid index or neither amniotic fluid properly. So objective assessment, you have to depend on the objective assessment, that is through the ultrasonography to measure. One is deepest vertical pool and another one is amniotic fluid index. Deepest vertical pool, if it is less than 2, then you can consider it as oligohydramnios. Or if it is more than 8, then you can consider it as polyhydramnios. So in between, this is the average or the normal range. So amniotic fluid index, it is more sensitive indicator of the amniotic fluid volume throughout the pregnancy. So it is sum of largest vertical depth of largest pool in each quadrant. So that's how it is to be measured. So that is silvers of the fluid, that is which is less than 1 centimeter wide, should not be measured. It should be more. So
अब आना
those
है, अगली बार जब तुम इना दिखाई देगा और पहले दिन हमें फोन करेंगे.
AFI varies with the gestational age. Therefore, this chart you have to measure. Measurement which is below 2.5 or above 97.5 are the significant. The it is 150 to 200 in AFI if it is measured with the mm. This is based on the gestational age. And the amniotic fluid abnormalities. So one is major amniotic fluid abnormalities. Nowadays it is more either oligohydramnios or the polyhydramnios. Majorly this oligohydramnios, you will see where the patients are not taking the enough fluid content, or if there is any circulation is hampered through the patient. So in those patients, majorly you can see, or the patients with the hypertensive, in those patients, you can see oligohydramnios more, and polyhydramnios, that patients who has blood-related problems like thalassemia or those kind of other related problems, or the patients with the history of diabetes, in those patients, you can see polyhydramnios more. Okay, so this is oligohydramnios. It is defined as reduced amniotic fluid. That is the amniotic fluid with index that on the ultrasonography which is showing less than 5 centimeter or even lesser than that, or the deepest vertical pool when you measure. So that if it is less than 2 centimeter, so then only you can consider it as oligohydramnios. In polyhydramnios, it is defined as the excessive amount of amniotic fluid of 2000 ml or more, or the in the USG, if it is AFI, if it is more than 25 centimeter, or the deepest vertical pool, which is more than 8 centimeter. Only this you can consider it as either poly or the oligohydramnios. So now we'll move on to oligohydramnios. We'll see what is there in the oligohydramnios. The oligohydramnios, that which is less amniotic fluid around the fetus. When there is less amniotic fluid, that which was giving support to the baby, so that will be affected. So when there is less amniotic fluid, that leads to oligohydramnios. When there is oligohydramnios, that affects the growth and development of the fetus. and there will be less protection as the cushion is not there. So oligohydramnios babies will be more prone for either any kind of injury or mild trauma if there is any gush. So in all this, there will be problem with the oligohydramnios or the fetus of the oligohydramnios. So that is why the extra care should be given through the for the patient with oligohydramnios. And the signs of symptoms of the oligohydramnios. So clinically, if the fundal height is not up to the gestational age, then you can think either it might be IUG or oligohydramnios. So you have to assess. So once you know clinically if there is fundal height is very less, then you can refer the patient or you can send the patient to ultrasonography. Then you can see based on the AFI measurement, then you can assess. So, or you can treat the patient. If there is decreased fetal movement, then there is high chance for it to more severe oligohydramnios. Then fetal heart rate will be tracing abnormality. So all these are the warning symptoms or warning signs for the doctor that it has to be treated emergency. If at all, if the only movements are less and the heart rate is minimal or it is maintaining, then you can send this send to the ultrasonography. Through the ultrasonography only you can diagnose, and then depends on how much it is mild, moderate, or severe oligohydramnios. Based on that, you can plan the treatment. The causes of oligohydramnios, one is maternal cause, where there is uteroplacental insufficiency is there, or if the patient is pre-eclampsia, or this is about the maternal cause, which leads to oligohydramnios, or the placental cause, that which is twin-to-twin transfusions is there. In those cases, there will be oligohydramnios, and in drug causes, prostaglandin synthetase inhibitors such as NSAIDs are taken by patients more. In those cases, oligohydramnios will be there. So that is why history taking is very much important in any for any clinician. And idiopathic, it might be anything. So then the complications of the oligohydramnios is in late pregnancy. There will be growth retardation or growth restriction or placental abruption. She might end up with the preterm labor. There will be fetal distress, or it might end up with the fetal death. Or with the if there is lesser amniotic fluid, it leads to baby will be under stress, that it will lead to meconium aspiration also. And labor induction in these cases, generally, it's always better go for cesarean section. And then this is the chikitsa which we follow in our clinical practice. That is Kshirapaka. In any kind of, what we suggest is you always take up such drugs that which has more of Madhuragana dravyas and Shitavirya dravyas. So that will always help for your practice. And Matra Basti or Basti we generally prefer, because there will be vitiation or the disruption of the Vata dosha or Apana Vata dosha at this level. So that is why generally Matra Basti will always be preferred. And Kshirabasti, Shatavarayadi, Taila Matrabasti, or Shatavaryadi, Kshirapaka, or Bala Taila Matrabasti, Vidaryadi Gruta, orally you can give, or Matrabasti also you can prefer, or Shatavari and Ashwagandha Kshirabasti also you can give, Shatavari orally, Churna also you can give, Shatavari Kshirabasti, Amagarbha Prayoga, this is one best Amagarbha Prayoga recently we have done. So this has given us the good result. So within a week, actually, 7 centimeter of the AFI has been increased to 13 centimeter. So this is one of the best recently what we have practiced. So, and then as Brahmaniya Gana Siddha Kshira Basti you can give, and Kshira Pana you can advise them to take more, and Yashti Madhu or Vidaryadi Siddha Kshira Basti, Ashwagandha Falagrita Kshira Basti, Pipalyadi Gruta, Prabhakaravati. All this, what it does is, this Prabhakaravati, why we specifically telling is, this increases the circulation. this increases the any kind of blockages, if at all, if it is there in the circulation or the vessels, this will be clearing out. And anything Pipalyadigrita which helps in the Rasadhatu Vriddhi, and if there is any problem with the Agni, even that can be corrected. So this Madhura Rasa and Madhura Vipaka, Shita Virya, this and all, which increases the Jala Tattva in the patient. So once you increase the Jala Tattva in the patient, generally it will also increase the fetal urine also. So in that way, it will help for the increase in the amniotic fluid. So Patya and Apatya, for generally for these kind of patients, we give Madhura Rasa Pradhana Aharas, that Kshira Anna, Narikela Jala is generally in those oligohydramnios patients, we always suggest them to take at least one Narikela Jala every day. And egg white is advised. And anything which makes them anxious or which is hampering their mentally or physically, those things are and all we'll ask them to avoid, or that which increases the vata. So those things and all should be avoided. And doing excessive work and all, we'll ask them to avoid excessive standing, excessive working or bending, any kind of things. And excessive intake of non-veg food, or that which has Ushna Tikshna Dravyas and all. So those things, or which makes them dry, or any Kshara which they are generally taking, those things and all, we'll ask them to avoid. And the person who does Upasa, generally we have seen in those cases, there will be higher rate of oligohydramnios. So that is why we'll ask them to avoid doing all kind of Upasa and Ati Vyayama and all Vyavaya, all this and all, we'll ask them to avoid. This is the Patya and Apatya. Generally, we ask them during to avoid during the oligohydramnios. And the treatment, the other than that, we'll ask them to take adequate rest. And then in either hydration, either ask them to take orally, or we'll give the, if it is very much severe and all, then we'll go for IV solutions, and which increases, though it is temporary, but immediately there will be increase. So we'll give them amino drip, RL, all this and all will increase their Jalatattva in that sense, if you say, though it will also be help in the increase in the amniotic fluid index. And serial USG, that is oftenly, you should keep on monitoring the growth and the AFI and fetal biophysical profile, so that the next, either we have to take up for the section, or we can maintain for the normal labor, or we have to keep on monitoring, so that the lung maturity or the maturity of the fetus takes place. At least it should reach the 37 week. So then induction of labor is done based on the lung maturity attained, or the lethal malformation, fetal geobardy, or if it is severe IUGR, severe oligohydramnios. In all this, if it immediately you have to go for delivery. And then in amnio infusion also can be given, which decreases the cord compression, so that it will help in the growth of the fetus. So this is how the assessment of the pregnant woman with oligohydramnios at term can be done. So the person who is at about 37 to 41 week is discovered with the AFI 5, which is below 5. So if at all, you have to see for if there is any ruptured membranes or not. If at all, if there is no ruptured membrane, that is well and good. If there is ruptured membrane, it's always better to go for the delivery. If it is not, then you have to see when is her EDD. And then NST should be done to evaluate the fetal well-being. If at all, if it is good, then you can put her on medication. Then you can go for other things, depends on your treatment. And the presence of pregnancy-induced hypertension, diabetes, and the other conditions, or it is associated with any uteroplacental insufficiency, or if there is IUGR or fetal anomalies, based on this, you have to see. And then if there is any abnormalities revealed, in any of the tests which you do it, either scan or any serum test which you do. If at all, if you know if there is any abnormalities, so better induce the labor, go for the delivery process. If at all, if there is no abnormalities, then you initiate the maternal hydration. So either with amniotic amino drip or IV drip, or give any busties which increases the fluid index in the fetus. Then you again check for 2 to 6 hours. Is the AFI is less than 5 only, then consider inducing labor. If it is slowly increasing, that is 5 to 8, it has slowly increased, then you go for measuring AFI again after 3 to 4 days. Then if at all, if it is not 5 to 8, it is not increased, then if it is AFI is less than 8, then perform AFI measurement NST weekly. And then based on that, either induce labor or you can maintain the pregnancy. So this is one important research which I have come across recently, that is low level of nitric oxide, which plays an important role in the pathogenesis of the pregnancy complications and the other diseases. So that is why this nitric oxide is very much important, which I felt, which I thought of telling you people also. So what is nitric oxide? This is an important messenger molecule present in the human body. Nitric oxide, known as the endothelium derived relaxing factor or the EDRF. So this endothelium inner lining of this is the EDRF, endothelium derived releasing factor. It's an inner lining of the blood vessel which uses nitric oxide to relax the smooth muscle, thus resulting in the vasodilatation and increasing the blood flow to the, there will be good circulation. So if this blood flow is hampered, only that leads to the other problems. That is this vasodilatation, it increased blood flow and permeability of the blood vessel through vasodilatation. If this is hampered, only then there will be decreased AFI. So that is why this blood flow should be maintained. Okay, it increases oxygenation, nutrients, and glucose availability to the muscles. So all these are clearly maintained if at all, if there is good circulation. If there is any problem with the nitric oxide, so then there will be hampering in the vasodilatation or the blood flow. So in those cases, that will, if there is nitric oxide is low level, then that decrease the normal functions of the placenta, and it is generally seen in the pregnancy-induced hypertension, preeclampsia or eclampsia, or in the oligohydramnios cases. So this is about the nitric oxide. So generally this nitric oxide is present in the L-arginine. L-arginine, as you all know, there are, it will come in the, you might get it in capsules also, you might get it in the sachets also nowadays. So this role of L-arginine in oligohydramnios, what does this do? This L-arginine is a precursor for the nitric oxide. So L-arginine is the precursor for the vasopressin. So if at all, if there is vasopressin is released, so that will increase in the amniotic fluid volume. So in turn, it helps in the proper development and the protection of the fetus. That in turn helps in the prevention and the treatment of oligohydramnios. So that is why this is L-arginine can be used in the oligohydramnios. Next, we'll move on to polyhydramnios. That the amniotic fluid index, which is more than 25, you can consider it as polyhydramnios, or the deepest pool volume. If it is less than, if it is more than 8 centimeter, then you can consider it as polyhydramnios. So it is the types of polyhydramnios is mild, moderate, and severe. If it is 80%, that is a pocket of amniotic fluid measuring 8 to 11 centimeter, then it is considered as the mild hydramnios. Moderate is that the AFI measuring 12 to 15 centimeter. Severe in there is about the 5% of the cases, twin to twin transfusion syndrome, where there is more than 16 or more. So this can be considered as severe hydramnios, polyhydramnios. So symptoms related to this is dyspnea, abdominal pain. Because of the over distension of the abdomen, that will end up with the dyspnea. As overstretching of the abdomen, that will end up with the abdominal pain and venous stasis. Contractions might be there due to overstretching. That might end up with the preterm labor, and there will be decreased perception of the fetal movements also because of the excessive fluid in the abdomen. So diagnosis, how can you do the fundal height if it is more than gestational age, or the difficulty palpating fetal parts, or the hearing FHS, or there is tense uterine wall, or ultrasonography. Through that, you can diagnose the polyhydramnios. And causes for the polyhydramnios, one is fetal causes either any kind of malformation with the esophageal duodenal atresia or tracheoesophageal fistula, or the anencephaly, which might leads to decreased swallowing, exposed meninges, or no antidiuretic hormone. In the twin to twin transfusion, there will be fetal polyuria. In fetal hydrops fetalis, there will be congestive heart failure, severe anemia. In all this, you can see there will be placental transudation. In diabetes mellitus, there will be excessive osmotic diuresis. And there is other causes also, that is idiopathic. And fetal prognosis worsens with the more severe hydramnios. That is, the congenital anomalies will be there generally. In 15 to 20% of fetal malformations will be seen. It might end up with the more of preterm deliveries. There will be suspected diabetes. There will be in the polyhydramnios, if you go for delivery, there will be prolapse of the cord and there will be abruption. So these are the few things which will be worsen the delivery. Then if you move on to mother side, there will be dyspnea, fetal stasis, placental abruption, uterine dysfunction, postpartum hemorrhage will be more due to over space or the over distension of the uterus. Then there will be immediate contraction might not take place as soon as the delivery takes place. So that is why PPH is a common symptom which you will see in polyhydramnios patients after delivery, and abnormal presentations will be more. So that is why generally it's preferred for the cesarean sections. So chikitsa which we give here is either Gokshadi Gugulu or Varunadi Kashaya, Punanavadi Kashaya, Kshirabasti with Punanava Ashtakakvata, which has little Ruksha Guna also. So that which reduces the Jalatattva in the fetus, and all this based on the USG guidance, you can prefer for a 3 days or a week or 10 days maximum. You can prefer all these medications. Generally, we give here for a week, and we have seen the polyhydramnios reduction. So the normal AFI I have seen after a week. So in that sense, you can prefer giving all these medications. It need not to be all this together. You can give just if you are not interested in giving Gugulu, you can simply give just Punanava Churna or the Gokshra Churna. Even that works. And Basti Karma, this is majorly because the Vata will be vitiated. There will be excessive pain and dyspnea for the patient. So if you give Basti Karma with any of the Kashaya, for as Matra Basti, that is 10 ml or 20 ml, you can, if you can prefer to give. That relieves the pressure symptoms like difficulty in breathing, which is caused due to the polyhydramnios. So Patya and Apatya for polyhydramnios is one is Lagu Ahara and Yavana can be given. And apatya, generally anything which vitiates the vata, that has to be avoided. Then management of the polyhydramnios in modern, generally what they prefer is there'll be minor degrees, there will be no treatment. So bed rest, diuretics, water or salt restriction, which is ineffective, what they have told, and hospitalization, if at all, if she ends up with dyspnea or abdominal pain or difficulty, ambulation, or which we have seen indomethacin. Even if you give this indomethacin, this will help. You can give it for only 3 days. The tablets that will help in the fetal, it helps in the absorption of the fluid from the amniotic fluid. So in that way, it reduces the fluid movements across the fetal membranes. So in that way, it reduces the polyhydramnios. Then complications of the polyhydramnios, premature closure of the ducts, arteriosus, impairment of the renal function, cerebral vasoconstrictions. These are the few complications which you might see in the polyhydramnios. So amniocentesis can be done to relieve the maternal distress and to test for the fetal lung maturity also. In the same method, you can just draw the amniotic fluid with the USG guidance. Then complications which we see in the amniocentesis is ruptured membrane, chorioamnionitis, placental abruption, preterm labor. All these are the common symptoms or the common complications which you can see with the amniocentesis. So what are the abnormal color of the amniotic fluid which you can see is, one is green, that is meconium. If it is green amniotic fluid, you can suspect as the meconium stained. If it is golden color, then you can say that might be RH incompatibility or the excess hemolysis will be there. So if it is saffron color or the greenish yellow, if you see, then it might be post maturity, or dark colored conceal it, that indicates it is concealed hemorrhage. If it is dark brown color, that indicates there is fetal intrauterine fetal demise. So while doing pervaginal examination also, you might get this color, or if it is rupture of the membrane, or if there is leaking. In all those cases, you can see the kind of amniotic fluid color and its significance of it. And case studies, this is what we have recently we have done. The role of Kshirapaka, we have asked them to take Kshatavari Kshirapaka, and we have given Kshira Andabasti. That way, I have told this is a new try which we have tried. That in the management of Garbhodakaksha, that is in the oligohydramnios, which we have tried. So in this patient, on the September 3rd, there was AFI 7 centimeter. We have given Shatavari Kshirapaka 20 ml orally, along with Kshira Andabasti 200 ml daily once for the 10 days. So after 10 days, when we have repeated the scan, the AFI was increased to 13 centimeter, and fetal biophysical profile was normal. Fetal weight was normal. So this is one which we tried newly in our college, and it has given a good result. So fetal movements and all, patients started experiencing it normally. So this is the few present things which I wanted to share with you all. Thank you. So it's open for the questions or anything.
Thank you very much, ma'am. It was indeed a very informative and a very interesting session. And thank you for enhancing our knowledge. So now we proceed with our Q&A session.
Everyone can keep their queries in the chat box. Dr. Charoyu wanted to ask something. Dr. Charoyu, you can unmute yourself and ask your query. I think she is not available. I'll take the next question. Details about Shira Andabasti.
Ma'am.
Hello, ma'am.
Yes,
Yeah.
ma'am. Shira Andabasti, how we did this? We have taken one anda, that is the egg actually, which is how do I tell in Hindi? I don't know the English. That is the nati koli antar, like we'll tell no, ma'am, which is the rural side, which has grown the good grown hen, the egg of an hen, that anda we have taken. So that is mixed with the 200 ml of milk, ma'am. The cow's milk. So that is with warm cow's milk, which is mixed. Anda is taken and broken at that time when we are giving the basti. So that is mixed well, and that has been given for the same as matra basti we have given for the patient, and we have asked her to maintain the position for half an hour to 1 hour until she is feeling fine, and then we have asked them to like she'll be in the ward, ma'am. So this is how we have given.
Yes, yes. Ma'am, one of the participants wants to ask you a question directly. Is it okay?
Yes, ma'am, fine, no problem.
Yes, I'm just unmuting that participant now.
Yes, ma'am, done. Ma'am, I'm not able to hear anything.
Yeah, I've just unmuted. Dr. Charoyu, you can go ahead.
Unmute her, Prajakta, from your side.
I have
Unmute her.
unmuted, ma'am.
Yeah, okay, okay. Dr. Sharyu, I think she is still unable to, I think, no, ma'am.
I think
Just
she
a
can
second.
put it on the chat
You
box.
can-
We can read it out.
Either you can,
Yeah.
if it is,
Just put it on
Okay.
the
She's
chat
typing
box.
on the chat box. She can just type the question. We'll read it out.
yeah.
Yeah.
Dr. Sharayu, please, I think there is some technical error. It would be better if you type it down. We'll ask Madam on your
Prajakta,
behalf.
have you unmuted her, na, you?
We
Yes,
have.
She's the
yes, I have
task.
unmuted. Yes, yes. And then the
But-
settings are such that, we can get unmuted ourselves also.
Okay. So either Dr. Sharyu, you can put your questions in the chat box and we will read it for you. Okay, so she's asking about the uterine artery resistance. So, means that I think she wanted to ask you regarding the sonological interpretation regarding the Doppler studies when we get in the oligohydramnios. So, can you explain it regarding in the way of interpretations that what we get with the Doppler study?
So I did not get you, ma'am. Sorry. I mean, I did not understand what is the question actually.
She's asking, so what I can read, she wrote only 3 words, that is uterine artery resistance, that we generally we found in the placental insufficiency, blood circulation get hampered and especially found in the oligo or the IUGR patients.
Yes,
So
ma'am.
I think she is wanted to ask you, in such cases, what should be the Ayurvedic treatment, how we should interpret it, and how to manage with that condition.
Ma'am, in those cases, that is what, that which increases the circulation. That is very much important because there will be artery resistance. So artery resistance here, you have to take it as it might be no problem with the circulation. In those
Yeah.
cases, you can go for the Prabhakaravati, ma'am. So
You
this is
explained previously about the Prabhakar Vati that which improves the blood circulation. Another what
exactly.
treatment? Another treatment. What should we give?
Ma'am, you can give anything which increases the Agni, ma'am. So even at
Okay.
the Dhatva-Agni level, so you can think about giving the Pippali churnas
Mm-hmm.
or sorry. So that which increases the Agni level. So in that sense, you can give this Shatavari also you can give. So in all these treatments which I've told so far, this is what we have tried and tested, and we have got the good results, ma'am. So
Yeah,
you
I
can
like
give,
that one. Previously, you explained with that example, na 7 AFI, and later on within the 10 days you got it.
yeah.
Best.
That is
But
the with
significant,
the Kshira
significant.
Anda Basti, ma'am.
Yes, yes.
So with that, we like it is a gross improvement within 10 days when you get the result so good. So why you have to go for the other invasive
Yes,
treatments and
yes,
all, no?
yes.
So
And
when you
in
can go for,
somewhere, even the Basti also works in that sense. When we said that Basti is also means one of the best treatment means in the obstetric practice, I came to know when I realized even right from the means induction of a labor or the other things like oligo and IUGR, I found a very good results to means with the Basti.
exactly, ma'am. You can give Falagrita also, ma'am. That which has
Yeah.
Madhura that which has good Madhura Rasa Dravyas in it. So
Mhm.
that will enhance the even fetal growth also, it will help. So
Yeah.
that is a overall uterine tonic in that sense you can give. And from the very first month, as soon as you got to know that she's pregnant, from that month till the delivery, you can give Kalyanaka Gruta or Falagrita. So all this and our Drakshadi Gruta. So all this will help in the circulation also, will help in the fetal growth also. So in irrespective of the months, you can give all this Grutas, ma'am. Ma'am, Prabhakaravati, we have given one BD, ma'am. I think that's a question which I saw in the chat.
Yeah,
Yes, yes, ma'am.
Dr. Pratiksha has asked dose of Prabhakar Vati and the Anupan and the dose of Shatavari Grut in Matra Basti.
Ma'am, Matra Basti, we generally start with the 50 to 60 ml of Matra Basti and we give till 120 ml, ma'am. So it depends on the patient also. Based on the patient, we change the mls. So, but it will be minimum to maximum is 50 to 120 ml, ma'am.
Dr. Sharu has also asked what is the role of sildenafil citrate tablet in uterine artery resistance?
For blood circulation, improvement in the blood circulation, actually.
Yeah, it helps in the circulation, ma'am.
And with the
Next
Prabhakar
question.
Vati, do you need an Anupan, ma'am? And what Anupan you give with the Prabhakar Vati?
Ma'am, Anupana is not needed, ma'am. You can give, or you can give with any Gruta also, ma'am. Generally, we prefer Falagruta, but in other way, if the patient is, many of the patients are not willing for the Grutas and all, ma'am. Then most of the patients will ask you give some tablets and all we'll take. Please don't advise us Gruta. That is, in pregnancy, many of the patients are not willing for the Grutas. So in those cases, you can generally, it need not to be any Gruta also. You can ask them to take with Jala, Ushna Jala or like that.
And what is the Ayurvedic management for IUGR is what Dr. Sharayu has asked.
Ma'am, in IUGR, you can first you have to elicit what are the complications, why she has ended up with the IUGR. So it might be anything related to circulation, either uteroplacental circulation might be hampered with whatever treatment I have told. If that is the problem, you can go for this. Or if there is other problems with the diabetes and all, like you have to see what is the underlying cause. Based on that, you can treat one.
Yes, one more question is there, which is very practical. That some
Yes, ma'am.
patients are reluctant to Basti. Some patients,
ma'am.
even after explaining, they don't take Basti. Then
Yes,
in
ma'am.
such patients, you know what to do.
Ma'am, so one thing, you can ask them to take orally, ma'am. If at all, if they are reluctant to for Basti treatment, you can ask them to take orally, ma'am. So this Phalagrita or Kalyanaka Gruta, all these are available in the capsule form. Even if they are not willing for in the Gruta form, nowadays we have evolved so much that even the Grutas and Thailas, you will get it in the capsule form. So you can
Correct.
prescribe them all this one.
Correct, correct.
But
Ma'am,
Prajakta,
also,
if you see now, the Basti, which is
yes,
the
ma'am.
metabolic effect that it has, the serum nitrate level, these are the marker of the
Hmm.
vasodilation, you can say.
Mhm.
So this
Yes,
ma'am.
VIP, there is a vasoactive intestinal peptides, when they get released after Basti, it causes the smooth muscles relaxations, which improve the blood circulations. And that is what is the main impact of Basti that we have.
yes, ma'am.
Correct.
And
Thank you for
after
the
getting the
input.
results, now you will fan of that Basti, you know.
Yeah.
Means why I am emphasizing on the
Yes,
Basti, because
yes.
I have
Yes.
treated my patients Basti. Means given beautiful explanations that regarding the AFI that when I found in the IUGR, yes, definitely I got the results, and somewhere it is related with your blood circulation also. So not medications, also Basti works in that.
Yes, ma'am.
Yes,
Thank
yes.
you for the input. It was a very nice information.
Yes, yes.
No,
Definitely,
ma'am.
ma'am.
Actually, I truly like your approach. Means what you have mentioned in your clinical means features. These are very, very important. I love that. Extremely good.
Thank you,
Extremely
ma'am.
good.
Thank you. Thank you.
Ma'am. Ma'am, one more question is there. This
Yes,
is
ma'am.
regarding polyhydramnios. This
Yes,
is
ma'am.
by Dr. Shilpa Shinde. If you
Yes,
give
ma'am.
Boxur or Punarnava in polyhydramnios,
Yes, ma'am.
it also works on fetal kidneys. Then how
Yes,
will it
ma'am.
treat polyhydramnios?
So that's how it will treat polyhydramnios, ma'am. So
Correct,
that's how,
correct. That is how it will treat. Correct,
because it is working on the fetal kidney. So
correct.
that's how it is reducing the fetal urine. As I've already explained through my slides, that after 20th week, majorly the amniotic fluid consists of fetal urine. So when that is reduced, so definitely your polyhydramnios, there will be reduction, ma'am.
Correct, correct. That is basically the mechanism of action, which is
Yes,
written
ma'am.
in the question. Correct.
Yes, ma'am.
Yeah. One more question regarding oligohydramnios. By
Yes, ma'am.
using Matra Basti or Sheer Basti for oligohydramnios, can it induce labor or preterm labor pain? This is by Dr. Aboli. This
Okay.
question.
So, ma'am, what I tell is Matra Basti, it will only help in the normalization of Vata, ma'am. It neither induces, not it'll it'll hamper anything. It is just normalizes your Apana Vata.
Correct.
So in that way, it will help in the normalization of each cell in and around where you give Basti. So then there will be, if there is any mild blockages or if there is any circulation. So what I have come across in my practice is, than orally, which you give basti, as in our classics also they have told, basti is the ardha chikitsa, ma'am. So
Correct.
whatever the treatment which you give, if you give basti, half of your treatment is already done.
Yeah.
So for the rest half
Correct.
only, we'll go for the treatments.
Very
So
true, ma'am.
in that way, basti works.
So
There's one
the
more
next,
question
yeah,
by
Dr.
Dr.
Chagusta, you can go ahead.
Yeah. Sometimes hyperemesis leads to oligohydramnios and in severe cases IUGR. Then what is the Ayurvedic effective Ayurvedic treatment for it?
Ma'am, in our practice, ma'am, if you give Draksha Digruta, that will help in the maintenance of your pregnancy. That will also combat your hyperemesis. That will also help in the circulation and the fetal growth also, ma'am. This is one best which we practice. Another one is you can give Eladivati, you can give Matulunga Rasayana. Matulunga Rasayana, so I have seen wonderful result in hyperemesis gravidarum, ma'am. So these are the things which you can practice, you can incorporate in your practice also, ma'am. Is that the question, or should I have to
Yes,
answer
yes.
something?
No. Everyone kindly keep your queries in the chat box. Kindly put the queries. Ma'am, I would like to ask one question from my side.
Yes,
So
ma'am.
basically, ma'am, do you use Vasant Kalpa in your practice? Lagu Malini Vasant, Madhu
Yes,
Malini
ma'am.
Vasant.
Yes,
And
ma'am.
how did you find the effects, ma'am?
Definitely, it is very good, ma'am. We generally give for like the person who, what I generally which I give is the person who is with the hypertensive patient, or who is a little stressed, or psychologically little depressed patient. In all those cases, I generally prefer Vasanta Malini, which will definitely help in the pregnancy and the circulation also, ma'am. So
Okay.
Vasanta Malini, definitely I give from the very first or second month only, I'll give, ma'am.
Yes, ma'am. Ma'am, and what about Udumbar gel? Do you use it
Udumbara,
frequently, ma'am?
Udumbara gel I don't use, ma'am, actually, but
Okay.
we don't use, ma'am, actually. Sorry.
Okay, ma'am. Okay, ma'am.
You use in your practice, ma'am?
I do use Udumbar gel, Lagu Malini Vasant, and I advise the patient to take Makhanas also.
Okay.
Ma'am, can you
So for
elaborate
all the
little bit?
patients, ma'am?
No, depending what the patient is having.
Okay.
I've actually published a paper also on this regarding
Okay.
Udumbar gel. Ma'am, can you explain the diet which we can tell the patients to take in oligohydramnios?
Ma'am, one thing you have to ask them to take, like liquid intake should be increased, and their excessive work, whatever they are doing, that has to be reduced. And if at all, if they are doing Ratri Jagarana, even that has to be reduced. So then you can ask them to take, as I've already told, that Narikela Jala, that definitely works wonders in those patients, ma'am. So then any Gruta daily, which is Satmya to them, which they might be taking cow's ghee, which generally patients take at home. So all those things you can ask them, and you can ask them to take more of Navanita, or this rice and all. You can ask them to take one. So all this generally they can take.
Yes.
And
Thank you,
it
ma'am.
also depends on which kind of desha they are in, ma'am. If at all, if it is Jangala Pradesha, definitely in those cases, the Jaliya Tattva will decrease in those patients. That might definitely hamper the patient. So it depends on the area of their stay also matters, which I feel.
Correct. Thank you, ma'am. Ma'am, diabetes mellitus, that is gestational diabetes mellitus with polyhydramnios. So
Yes,
any
ma'am.
change in the treatment or anything which can be added in this?
Ma'am, you can include the treatment for the diabetes also. So which like Nishamalaki or Madhunashini, whichever you are preferring for the diabetes, those medicines you can add on with all these medications. That you are asking for oligo or poly, ma'am? Polyhydramnios, right?
Polyhydramnios, correct.
Ma'am, you can give Basti. Even in diabetes also, you can give Basti, ma'am. That will definitely works.
Okay.
Or
Thank
you
you, ma'am.
can ask them to take Takra also, ma'am. Takra will definitely reduce the excessive, that is one Ruksha, which will help for the patient. So you can ask them to take daily Takra also, ma'am.
Okay, okay. Ma'am, what would be the dose?
Ma'am, Takra, it will be 50 ml to 100 ml, depends on the patient. You can, depends on the condition also, you can take, ma'am, 50 ml to 100 ml.
Yes. Thank you, ma'am.
Yes,
Ma'am, yeah, one last question from my side. So
yes,
whenever
ma'am.
we think about delivering a patient who is having polyhydramnios, so
Yes, ma'am.
what are the things to keep in mind, and what challenges should be, foreseen, and how to act on it?
So, ma'am, generally in polyhydramnios, either it will be big baby.
Hmm.
So, another thing there might be cord prolapse. So, for all
Yes.
this, you have to be ready that the immediate section, if at all, if any chances, then you have to be ready for it. Then, if at all big baby, you cannot deliver normally, no, ma'am, unless it is that much space. If you have, then you can go for it. And you should never do fundal for all those patients. And then in polyhydramnios, there is always chance the uterine tonicity might after delivery, if at all, if it is not big baby, neither cord prolapse, patient delivered, all good, then everything is
Yes.
fine. But still, after delivery, the placental separation might be hampered and uterine tonicity will not come immediately. So blood transfusions should be maintained and her vitals should always be kept under tips. And then if at all the tonicity is not maintained, then immediately hysterectomy should be done, ma'am. I
Correct.
mean,
Correct.
we can control if at all, that is the maximum extent, like we can maintain. If at all, if it is not, then you have to go for hysterectomy, ma'am.
Correct. Correct.
But all this should be priorly explained to the patient and patient party. So otherwise, we'll be in danger.
Correct. Correct. Yes. Thank you, ma'am.
Yes,
Over
ma'am.
to you, Dr. Chabukta.
I think there's one more question by Dr. Sharayu. Do you have any specific protocol for preconception for a Swastha Garbha?
Ma'am, generally here we go for routine panchakarma, ma'am. So then we'll elicit if at all the family tree, what and all, they have their that history and all we'll completely take. So then we'll go for the all the panchakarmas, that is Vamana followed by Virechana and the Basti and Nasya. So once it has been done, then we give, we'll go for the Rasayana Chikitsa for both parents, I mean the mother and the father, male and female, for both the patients will go for the Panchakarma tree protocol and then followed by Rasayana and Vajikarna therapies. So that's what we give.
Dr. Prachi, you want to ask?
Yes, ma'am. On behalf of NIMA OBGY, am I audible, ma'am?
Yes, ma'am. Yes, ma'am.
Thank you so much, ma'am, for such a wonderful session. On behalf of NIMA OBGY Society, Central Maharashtra body, I would like to express my deep gratitude to NIMA Central President, Dr. Ashutosh Kulkarni, sir, and Secretary, Dr. U.S. Pandey, sir, and Treasurer, Dr. Shantilal Sharma, sir, for such a remarkable support. I extend my gratitude to our NIMA OBGY Central President, Dr. Kamini Dhiman, Madam, Secretary, Dr. Priyanka Nakade, Madam, and Treasurer, Dr. Vishnu Bhavne, sir, with convener Dr. Rajesh Utare, sir, for supporting and guiding us to conduct today's webinar. I would also like to thank and extend my gratitude to our eminent speaker, Dr. Chetna Kumari, Madam, who took time from her busy schedule and delivered a very knowledgeable and wonderful session. This is going to be very helpful for all the participants in the future. I would further like to extend my gratitude to NIMA OBGY Maharashtra President, Dr. Suhas Herlekar, sir, Secretary, Dr. Manoj Gaikwad, sir, Treasurer, Dr. Ajay Raj Bal, sir, for all their support to conduct today's webinar. I would like to thank Dr. Girish Daga, sir, and Dr. Apita Shah, ma'am, for all the help and technical support. Last but not the least, I would like to thank you from my bottom of heart to all the delegates for their active participation and presence. Without them, this webinar would not have been possible and successful. Now, with the due permission of all the dignitaries present in this webinar, I am concluding today's webinar. Thank you all for attending this webinar session. Thank you, ma'am, for such a wonderful.
Thank you so much, Chetna, ma'am. It was really a treat for us. And I think if the delegates, if they have any queries and still they want to ask some questions, madam is there in the group. So you have the day, whole 24 hours, you can ask anything regarding the oligo or the polyhydramnios. If any queries you people have, you can put it in the your WhatsApp group. She will definitely answer you. So you can carry on your questions and answer in the group also. Thank you, ma'am. Thank you so much for giving us time.
Thank you, ma'am.
Thank you so much, ma'am.
Thank
Thank
you.
you so much, ma'am, for delivering such a knowledgeable session, ma'am.
Thank you, ma'am.
Thank you so much, ma'am.